Over the past 50 years, there have been significant concerns that the heart might be severely involved in patients with scleroderma, and that this might be a cause of much of the mortality in scleroderma. The data is predominantly retrospective, so we don't know if it's true or whether it's just an association. What we have shown is that coronary disease occurs in the same frequency in this population as it occurs in those with the normal population. Looking at the conditions that we do see, we find an inflammatory myocarditis, we find pericarditis, which is also inflammatory, and we can find restrictive cardiomyopathies. The cause of these conditions in scleroderma is as yet unknown. There is competition between two views. One is that it's predominantly an autoimmune inflammatory problem, and the second is that it's caused by spasm of the small blood vessels called myocardial Raynaud's. As yet, we don't know the appropriate treatment for this population. We predominantly diagnose it and treat on the basis of gut feeling at the present time.
Lung complications of scleroderma include pulmonary fibrosis. Lung fibrosis causes progressive scarring of the lungs, similar to that occurs in the skin in scleroderma, but in the lungs there's the additional problem that as the lungs scar, they're less able to exchange oxygen and patients become breathless. Lung fibrosis is a condition that requires careful investigation, and often a number of different tests are required. The first tests will be lung function tests performed in a lung function laboratory where where the volume of patients' lungs will be measured and their ability to transfer gas across the lungs determined. Patients will then progress often to having a high-resolution CT scan, which allows the precise definition of the extent and severity of the fibrosis within the lungs. Using this information, and also that obtained from other specialist tests, doctors can make the decision about whether the patient needs to have immunosuppressive therapy and steroids for their lung disease, or whether they can simply be kept under observation.
Probably the most important complication of systemic sclerosis at present is pulmonary hypertension. Previously, renal disease was the main problem, but now pulmonary hypertension is one of the lead causes of death. The predominant symptoms are of breathlessness, chest discomfort, and blackouts. Any of these symptoms in patients with systemic sclerosis should make one think of the possibility of pulmonary hypertension. There are two ways that we go about ensuring that patients with pulmonary hypertension are diagnosed early and managed. Firstly is through screening programs. Patients should have an annual echo and should be asked annually about whether or not they have got breathlessness. Any new breathlessness needs to be explained and the cause found. The second way we go about it is by investigating all symptoms very early and very thoroughly. So if we find someone with breathlessness, we know that pulmonary fibrosis, another complication of systemic sclerosis, is a common cause, and we will investigate for that. But very early, we will do an echocardiogram, and if there is still any suspicion, even if the echo has been normal, we will proceed to cardiac catheterization. By this method, we pick up most patients who have got systemic sclerosis associated pulmonary hypertension early, at a time when we can treat it and the prognosis is relatively good. If we wait just 6 or 12 months till these patients develop end-stage right heart failure, then you end up with a 40 to 60% annual mortality. So early diagnosis is the key in patients with systemic sclerosis-associated pulmonary hypertension. The agents we use to treat pulmonary hypertension form three groups. The phosphodiesterase inhibitors, we think typically of sildenafil or Viagra. The endothelin antagonists, typically one would think of bosentan. And the prostanoids, epoprostenol would be a good example of this. The main problem with the therapies is their side effects. So I'll deal predominantly with those. Bosentan, the endothelin antagonist, causes liver problems in about 1 in 10 patients. If this is picked up early, it is no problem, and therefore we do blood tests monthly for the first 6 months and then 3 monthly thereafter. If one ignores the abnormalities and forgets to do the blood tests, then you can end up with severe liver damage, which would be irreparable. This has not happened to date in all the patients treated in the UK with bosentan. The second problem with bosentan is that it does interfere with warfarin, and therefore when starting it, since all these patients are taking warfarin, it is important to watch the INR closely. It tends to go up. When one comes to sildenafil, or Viagra, the second agent we use, another oral therapy, the main problem here from the patient's point of view are nosebleeds. There are many suggestions in the literature that they can cause eye problems and heart disease, but this does not appear to be a significant problem in our population. When one looks at the prostanoids, we frequently give these through continuous intravenous infusion, and approximately 10% of patients per year develop septicemia. Because of this, one has to be very aware of the many presentations of sepsis. They don't all get temperatures and sweating and know that they've got an infection. Some just feel fluey, generally unwell, and begin to lose weight and become more breathless. So any major change in the well-being of somebody who is on intravenous therapy should lead to them being referred back to the hospital. The subcutaneous therapy group do suffer from a lot of abdominal pain with it, and we try many different therapies for which there's very little evidence to try and help them with this pain, but most get through it. About 60% can manage, but it is continuously uncomfortable. The other major complications of prostanoids are jaw ache, diarrhea, and abdominal pain. These tend to be minor problems from the patient's point of view, and dose adjustment helps these particular symptoms.